Just talk. He's my. Just talk.
Okay. Thank you. It's a beautiful night here in Providence. My name is Anthony Napoli. I am the Academic Director of the Masters of Healthcare Leadership Program here at the School of Professional Studies at Brown University. I am also a board member on the Rhode Island American College of Healthcare Executives, and we are very fortunate tonight to have our first co-sponsored event between the American College of Healthcare Executives and the Masters of Healthcare Leadership Program here at Brown. Tonight's event is titled The Future of Healthcare Here in Rhode Island. And we have an amazing panel of speakers here tonight. For those of you joining us online, if you have questions for the panel, please submit them to the chat function. We will collate them and ask them of our panel. For those of you here in person tonight, if you have a question, please raise your hand and I will circulate with the microphone. Introducing our panel tonight is our moderator, Dr. Marie Ganem. She's a clinical assistant professor of policy and practice here at the School of Public Health. She's a former health insurance commissioner in Rhode Island, and she's now an instructor in the Masters of Healthcare Leadership Program in the course Healthcare Policy. Dr. Ganem.
Thank you, Anthony. So we're going to begin today with a little bit of background as to why we're here. I'm going to begin with just a few fun facts. Healthcare in Rhode Island is an $8 billion industry. We very rarely refer to it as a system, I think because people are aware that we don't operate like a system. It is an industry, but $8 billion. We have a high percentage of insured in our state. We're well aware of that. We do a great job of covering people. We've got some folks on this panel today who are responsible for some of that, with very low percentage of uninsured. But what are the problems there? We have folks who cannot afford their out-of-pocket expenses. We have very high premiums in the commercial market. We also are very acutely aware of some of the problems that we face in the healthcare system that are not unique to Rhode Island relative to workforce, relative to quality of care for folks from diverse populations, relative to access to behavioral health services. These are all challenges that we face, and these are challenges that hopefully the panel will be able to address further. Rhode Island's hospitals have a history of having a low profit margin. People blamed me for that when I was the insurance commissioner. However, I'm not sure we can take full credit for that. When you look at the margins, the profit margins across our state and compare them to other states and nationally, our average profit margin in 2020 for our hospitals was about 0.5%, so a half a percentage. That was the profit margin. So some hospitals were higher, some hospitals were lower in the negatives. When you compare that with other states, when you compare that with the national median, 5% was the national median. So to show you what the picture looks like, and I know Al's going to get right into this when he addresses some of the issues, but we do have this situation, and we know that a number of our hospital systems have just recently reported very significant financial losses. We know that COVID-19 exacerbated underlying weaknesses in the healthcare. And even though we received $580 million in COVID relief in our state that was distributed to our providers, $580 million, we still had tremendous challenges that we needed to overcome, including our staffing and workforce challenges. The biggest issue facing workforce right now also is the fact that we have an aging population, so people who need care, so there's more need for care, but also the aging of our workforce. The average age of our physicians is about 55, and people are retiring at a more rapid pace now, possibly due to burnout. So we have that added challenge. And then finally, for those of us from Rhode Island who watch what goes on here, the soap opera that's been playing out for more than a decade between Lifespan and Care New England has been a very rocky one, right? It's very suspenseful. And we never knew, are they going to marry? Or are they going to get divorced? Well, there was a decision made that was pretty emphatic. And now we are all asking ourselves, where do we go from here? So this panel tonight is perfectly assembled to address the where do we go from here. So let's start with the question that was posed to each one of the members. And Orla Brandes, I'm going to introduce you first, if you don't mind. And we want to extend our gratitude to each and every one of you for being here. So the question that we asked each one of them and what each panelist is going to address is, from your vantage point and perspective, what are the key 1 or 2 things that Rhode Island could do to stabilize and improve our healthcare system? Given the pressures and challenges, what does the future look like? Is there potential to improve the prognosis? So Ola Brandos, thank you so much. Ola has so many initials after her name that I'm not even going to list them all. But she has her doctorate as a nurse practitioner, and an MBA, and an MSN. She's Vice President of Patient Care Services and Chief Nursing Officer at Newport Hospital. She is also an American Nurses Credentialing Center appraiser for the National Magnet Program for Nursing Excellence. Prior to joining Lifespan, Dr. Brandos was the Associate Chief Nurse for Maternal Child Health, Ambulatory Nursing Services at Newton Wellesley Hospital in Massachusetts. She also served as the Vice President of Patient Care Services and Chief Nursing Officer for Morton Hospital, Stewart Healthcare System in Massachusetts. Dr. Brandos, thank you so much, and please let us know what your prognosis is for Rhode Island.
Sure. So I'm going to give my perspective. Can everyone hear me okay? For working at Newport Hospital and Lifespan, and what I see on a day-to-day basis is the challenges that we are faced with every single day. And the number one issue is workforce. Lack of a workforce in every discipline. And like Marie said, I oversee nursing, but I also oversee a lot of other departments, the laboratory, diagnostic imaging, they all report up to me, wound center. And for a short time, I had rehabilitation services, so physical therapy. People are not wanting to work like they used to before the pandemic. And we're seeing such a shift in early retirements, folks going into other areas outside of healthcare and just not wanting to come into work. And the reality is here in Rhode Island, and I'm sure many of you can attest to this, is the workplace violence that we are seeing in our emergency rooms, in our inpatient units. Nurses, doctors, you name it, no matter what kind of a caregiver you are, they're coming to work, they're getting punched, they're getting spit at, they're getting sworn at. It's actually very challenging. And then dealing with the mental well-being of our workforce and how we can support them on a day-to-day basis. You know, the security officers in our emergency department that come into work and they're giving up. They're saying, why would I come into work every day and get beat up when I can go work at Target for $24 an hour and have a nice cushy job and not be working nights and weekends? So I think for Rhode Island, and it's not just Rhode Island, it's the whole country, we're all dealing with this. How do we encourage our next generation of workforce to want to work in the healthcare setting? We're always going to need an emergency room. And how do we make that attractive and pay our workforce what they deserve? The Rhode Island, the state has one of the lowest salaries for nurses, for medical imaging. We're really behind the forefront of what the salary range is. But in addition to that, then our reimbursement is terrible, as we all know. And it's very difficult for hospitals to make the appropriate margin to be able to pay the workforce. So I think number one, that is definitely an area that as a state, we need to come together and make it an attractive place for people to want to come to work and for it to be affordable. So in Newport, we have doctors, we're trying to recruit doctors and they cannot afford housing in the Newport, Aquidneck Island area. So if our doctors who would be getting a decent salary, cannot afford an apartment or a house, how can the environmental services employee who's getting $15, $17 an hour come to work? And we need those folks. We need them to be able to keep our hospitals clean, to the day-to-day operations, our materials management folks who get us the supplies to be able to care for patients. So I think it's it's so complicated and needs so many fixes. So workforce is number one, but place to live and affordable housing for our workforce. And I would assume that it's the exact same here in Providence. It's very expensive to live. So that's, I think, my number one issue. And I think the other thing for Rhode Island to think about, behavioral health is our pandemic. That is our new pandemic, and childhood behavioral health is just out of control. And we've got Dr. Anthony Napoli here, who is our emergency room medical director. And we are seeing children in our emergency rooms for days and days and days, and there is no place for them. We're just babysitting them in our emergency room. There's not enough beds in the state for children, adolescents, and even for our adults. We could close Newport Hospital and just open it up and be all behavioral health, and it would be filled within an hour. And that's like 130 beds. So what can we do as a state and as all of these disciplines come together to be able to build something that we need? This is not going away. It's only getting worse. It seems like day by day. And that's where I see a lot of issues for us as we move into the next few years with behavioral health. And at our state, in our emergency rooms in the Rhode Island hospital, they have got 40, 50 patients just waiting for beds and nowhere to go. Last week, we had a 6-year-old child for 13 days in our emergency room, just sitting, waiting. And we're providing no services because there was no beds available at Bradley Hospital, Butler Hospital, and 6-year-old. And we're seeing more and more of that age group. So we need to really get our politicians involved and support the what is the real pandemic. Put the resources into that. So.
Well, that's thought-provoking, Ola. Thank you so much for that. But perfect segue, I think, to the next speaker, who actually spends a lot of time focusing on some of the social determinants of health, as well as some of the behavioral health issues and challenges. So that was a great segue, and a little depressing, but that's okay.
It's reality,
It's reality,
yeah.
unfortunately. Yes, thank you. So I'd love to introduce our next speaker, who is no stranger to the challenges confronting healthcare in Rhode Island. Since April of 2019, Marty Rosenberg has served as the Director of Policy, Planning, and Research for the Executive Office of Health and Human Services. And for those of you who might not be familiar with the Executive Office of Health and Human Services in Rhode Island, it is the state agency that oversees public hospitals and Medicaid, along with a host of programs that support people that impact the social determinants of health. Prior to her years at EOHHS, Marty was the project director for the Rhode Island State Innovation Model. And prior to that, worked as a chief advocate responsible for the protection of our right care program and for numerous healthcare initiatives in the state. So it's my pleasure to introduce Marty Rosenberg.
Thank you. Thank you so much. It's great to be here. You looked at my notes. I think you stole my notes because my first two things were going to be workforce and behavioral health. So I am going to, so this is good. This is a consensus building here. I'm gonna leave workforce because you really handled it well, but I am going to go deep into behavioral health and talk about some of the things that EOHHS is doing, because I think there's a little bit of a path forward that we can imagine to address. So yes, on workforce, and absolutely we need to recruit and support, especially people who represent the racial, ethnic, and cultural diversity of the state. So it's not, we need to recruit and improve our equity of our workforce. But let me talk about behavioral health. So EOHHS is focused on behavioral health transformation. And so if we could achieve what I'm about to lay out, it would really help the future. So first, certified community behavioral health clinics are the system changing structure that SAMHSA and CMS have both created. They've worked together, and just today was announced a new grant for the ability to increase the federal reimbursement rate. So we are going to be applying for that grant, but we are excited to have $30 million that we are about to put out into the community to support the entities that can be certified community behavioral health clinics. These are entities that will cover 9 critical services, including mobile crisis, which is going to help what you're talking about. It's not going to fix, but it's going to help what you're talking about with folks stuck in the emergency room, because the folks who don't need that level of care will have some place to get, and all of CCBHCs will allow folks who don't quite need inpatient care, but don't have anywhere to go for that transitional time when they're in crisis and they need assistance. The CCBHCs will help them, the mobile crisis will help them. And added to this are designated collaborating organizations. And these are in Rhode Island going to be children's behavioral health providers, SUD providers, specialty behavioral health providers, and equity partners. And so the point of creating and investing in these entities and the structure of the certified community behavioral health clinics, which will each be in catchment areas to cover the whole state, and the designated collaborating organizations will be, you can't just wait for people to come to the door. You have to go find them. We have to go find them. We have to go knock on doors. We have to go to encampments and under bridges and in housing, homeless shelters, and find people who need the services, provide them the range of services that they need with care coordination and care management and extensive amounts of services. Is this cheap? No, it is not cheap. We need an investment in our behavioral health, because you're right. It is the pandemic, the next pandemic that we're dealing with. And so is the opioid crisis, that part of the crisis. And so I'm pleased to say that EOHHS has been tapped to be the entity that is putting out into the community the dollars from the opioid settlements that have been happening. Our Attorney General has secured over $190 million over the next 18 years. And EOHHS is putting out this year $20 million in projects for harm reduction and treatment and recovery and prevention for kids and others. And so making these investments in a smart way, making sure that we use data and we evaluate them and find out what works and continue on with what works. Don't fund the stuff that doesn't work. Stop funding that. That would be good. And then my final piece, so I'm doing 2.5, is a lot of what we're talking about is fully focused on the social determinants of health. When we talk to everybody, and I mean everybody in the opioid sort of adjacent world, everybody in the behavioral health world, the one thing that they said, if you could do one thing, it would be to fix our housing issues and make sure that people have homes, places to live, safe, secure places to live in. So a lot of the opioid dollars will go there. And the administration is putting $250 million into housing, and we at EOHHS are working with them to make sure that those dollars that are aimed at our most low income are spent right, are spent smartly, and we evaluate that too. And just a push for housing first, which is a methodology that says if you have a substance use disorder, you can still get a house. We'll help you with treatment afterwards, but you shouldn't be disqualified from housing help because you are using drugs. So those would be my top priorities.
Great, thank you, Marty. Well, I don't know if anybody thought before we came here that our conversation about healthcare would really be a conversation about workforce issues, violence, and behavioral health. So thank you. Those are both very provocative and very much related presentations. Thank you. So next, please join me in welcoming Nick Lefebvre. Nick is new to Rhode Island, and as a result, will give us a fresh perspective. Don't tell us exactly what you think of us, but so Nick has a master's in public business administration, right?
Yep.
Because I got all this online. I'm hoping it's accurate. Since this May, Nick has been Senior VP for Value-Based Care at Blue Cross Blue Shield of Rhode Island. In this role, Nick links value-based care models with health systems, pharmacies, primary care, and other health provider groups. This is a new leadership role created by Blue Cross Blue Shield of Rhode Island, aimed at serving more members within a coordinated system of healthcare providers. We know that's no small challenge. Prior to joining Blue Cross, Nick spent 8 years in growth and upward movement with DaVita Inc., which is a dialysis care organization, a kidney care organization, where he focused on commercial value-based contracts, strategies, and analytics. He graduated from Middlebury College and earned an MBA from Dartmouth College. Take it away. Let us know what you think.
Well, first of all, thank you for having me to talk about super important issues and on a beautiful night in Providence and what is an absolutely beautiful building too. I was just walking around. It's just amazing. It feels brand new. And turns out it is, since it opened in 2019 and basically wasn't used for a little while. But as was mentioned, I did work on the provider side before. Totally echo all of the comments before, especially about the workforce and how challenging that can be. I also think that, and I'll take it in a little bit of a different direction, we have a big opportunity. And at Blue Cross, we believe we have a really big opportunity to figure out how value-based care works better in the state. One of the things that is really exciting is the foundation that we have in place, where 60 to 70% of our membership is in a value-based care program today. An ACO, a PCP attributed ACO that puts the PCP at the center of care, acting as the quarterback, which is exactly what you want to have for a healthcare system to be working well. And value-based care, it can sound like buzzwords sometimes. It's a win for affordability. It's a win for the patient because of cost and because of quality and better clinical outcomes. It can be a win for the provider by generating a new revenue stream. But it really can work with the right level of investment and the right level of focus, because you can get people thinking differently about the day-to-day and make that PCP think more holistically to try to keep the patient healthy and out of the hospital, to figure out how to coordinate better with the highest quality specialists to better integrate that care. The foundation is in place. It's a very exciting thing about the state, about the market. There are not a lot of markets where you can say 60 to 70% of patients are in a value-based care program. But we have to take it to the next level. We have to say, how do we move from what are relatively basic value-based care contracts that exist today without much upside, without much downside, that don't incentivize really advanced value-based operations, to much more mature and sophisticated value-based contracts, like total cost of care contracts on the commercial side, Medicare global cap contracts, where the provider not only takes on more downside risk, but takes on 100% of the upside risk, and then is really incentivized to lower the cost of care because it turns into a new revenue stream for that system. It takes time, and it is hard, and it is scary, right? I was on a provider who made this shift, and it was really challenging. But it's also possible with the right levels of investment and the right capabilities. And so what we're trying to think about is, how do you bring the right capabilities to the market to help transform the care, to help transform the delivery models, to help practices just think differently about team-based care, about using data more sophisticatedly, and how do we get to the next level? Because you want to ensure, obviously, that anyone who's going to take on that type of risk is going to be successful, and that any provider is going to sign up for it is going to be successful and has the right support. But if we can do that, it really can be a win for affordability and a win for clinical outcomes, and a win for the providers to generate new revenue streams, to have a more sustainable economics and more sustainable outlooks. And then they're no longer buzzwords. It's the reality of what we can do in the market, and the foundation is in place. It's just a lot of work to make that transformation.
Great, Nick. Thank you so much. I think providers during March of 2020, was that when the pandemic hit? Everybody quickly learned that having a stable source of income would have been nice, and not having to have fee for service as their primary method for payment. So I think that the work you're doing is much better received hopefully now, and hopefully it will be, the take-up will be great. So thank you so much. And he didn't mention the fact that we don't use our directionals here, which is, but so, this next speaker, someone, oh God, Al Charbonneau, I don't even know how long I've known Al for, but we go back a ways. So Al, unfortunately, I left your bio over there, but I think I know it. So Al came to back to Rhode Island after going to URI, and worked in Rochester for a while. And in Rochester, he was a hospital administrator and very intimately involved in an experiment that was successful relative to hospital financing. And when Al returned to Rhode Island, he wanted to educate us, and he wanted to assist us in making transformations in terms of healthcare financing. Al then became the executive director of the Rhode Island Business Group on Health. The Business Group on Health is the organization that represents the major employers in the state who purchase health insurance. And they have, of course, a vested interest in not only healthcare costs, but also the quality of healthcare for their employees. And many of you who come from health systems, your health systems are, of course, our employees who are purchasing health insurance and have a stake in the affordability of the services. So Al has been a partner. He's been very active in influencing government and I think influencing public opinion based on healthcare affordability, and is never shy at events like this. So Al, please let us know what you think we need to be doing next.
Well, my assignment is to say what business wants, so I'm going to at least talk a little bit about that. And I think I can sum that up in three phrases, business, or 3 words. Business wants predictable, affordable, high quality healthcare. They don't want to be bothered with, frankly, worrying about what the next premium is going to be, or whether or not the hospitals are making money, or whether the plans can cover their costs, or any of that sort of stuff. That's not their business. They don't want to be in the trenches trying to figure out what to tell the legislature to do. They want the system to work. In fact, there's a woman, and I won't tell you her name, but she's a senior vice president for benefits who came back from running I guess an international company, benefit director for an international company that recently joined the board of the Rhode Island Business Group on Health. She spent 12 years in Brussels and said to me, Al, what's wrong with our healthcare system, if you think about it, because most people don't have the problems that we have. Since we're being paid by the word, however, I'm going to move on and talk about a little bit more. And by the way, I don't want to be offensive to anyone from the hospital world. What you guys and girls have been through in the pandemic is nothing like I've ever been through. And I went through, C. difficile and flesh-eating bacteria and all that sort of stuff, not to mention a number of union attempts and that kind of stuff, but never, ever have I been through anything like the pandemic. So I think my feeling with respect to the pandemic is that it is an opportunity to do something different. The first time I heard that the healthcare system was imminently going to change, unsustainable, was when I graduated from the Graduate School of Business at Cornell in 1974. It was about to collapse on its own. And during that same period, we talked a lot about a new model for hospitals. And frankly, I think that's where we do have an opportunity here in the state to rethink what we're doing. Because just off the top of my head, some metrics. For example, our family premiums, well, Marie knows this better than I do, large and small group, commercially insured, book of business has declined by almost 50% in the last 10 years. Now, some of those people went self-insured. Some of those people may have gone elsewhere, who knows? But that is dramatic, frankly. If you look at family premiums here in the state, they're approximately 28% of median household income. Now, that's a bad metric to start off with because it doesn't incorporate what the employer pays. But still, I mean, it's what the University of Pennsylvania is using. Zeke Emanuel developed it. And I mean, it should give us pause, even though it excludes the commercial insurance. When the employer's share, when I hear about hospital costs, I've done a lot of work on hospital costs, probably addicted to the damn subject. But I see, when I look at overhead costs here in the state of Rhode Island, we're approximately 21, no, not 21%. We're about 56% of total costs. We are the highest in the nation as a state, when you look at overhead costs. When you look at costs, what I consider non-reimbursable, so things like home office costs and related organization costs, they are now 21% of total expenses. I'm not certain that the most talented management group in the country could generate a margin with that level of non-revenue producing expenses in your budget. And it feels to me like we took an off-the-shelf model called the hospital system, and we built it for a little less than 1 million people. And I'm not so certain that that works, that I think the requirement would be to really rethink and move in an entirely different direction. I think that, and then, and I'll stop in 2 seconds. I think that a refocusing of hospital systems on affordability, on quality, I think is absolutely critical. I'm not one that thinks you should take the hospital system apart, but I do think if we looked at this thing over 10 years, and it really is 20 years or more, if you think about the ACO is built on the hospital system chassis, I think we have a tremendous opportunity to both change hospitals and to strengthen hospitals. I'll stop.
Thank you, Al. That was great. And certainly something to think about as we look at the fact that we don't have the merger moving forward at this point in time between Lifespan and Care New England. It is an opportunity to take a step back and say, what do we need? But why that's provocative is who directs that activity, who moves us in the right direction? Because after all, this is an industry, right? And folks are going to be looking for where their dollars are coming from. So that's certainly where Nick's work comes in. Thank you. So next, last but not least, Lindsay Lang. Lindsay is an attorney, also someone who has been on the healthcare forefront here in Rhode Island for a number of years. I first met Lindsay when she was an attorney working in the Lieutenant Governor's office and just happened to be at the right place when the Affordable Care Act passed, and the Lieutenant Governor's office was charged with actually implementing that in the state. And Lindsay led that charge and is really responsible in so many ways for the consensus building that needed to take place to move the Affordable Care Act pretty quickly toward implementation in our state. Lindsay is an attorney, again, she got her degree at Suffolk Law School and went on to work at the Exchange and has been there for about 9 years since the Exchange was created, right? And she started out as a legal counsel, moved up to chief of staff, and then a couple of years ago became the executive director. And I'm so glad to call Lindsay a colleague, and hopefully we'll hear some words of wisdom about health insurance and affordability in our state. Thank you.
Thanks, Marie. I was supposed to be a criminal defense attorney, so I blame people like you and Marty for pulling me into health policy and the lieutenant governor at the time. I'm going to take a slightly different perspective. So as the state-based marketplace, if you're not familiar, we serve primarily the individual and family market. We are created under the Affordable Care Act and have about 30 to 33,000 lives enrolled through our marketplace in commercial coverage, which also connects enrollees to federal advanced premium tax credits, which bring down the monthly and yearly cost of enrollees' premiums through the tax filing process. We also run a small business program, which serves about 1,000 Rhode Island small businesses, about 7,000 lives. And I guess I wanted to just bring the perspective of our enrollees and the sort of the experience of the individual and family market since the inception of the ACA in Rhode Island. And I think one of the things that, you know, I'm sitting here to talk about is affordability, and it certainly remains a concern of marketplaces around the country and here in Rhode Island, because we have, as Marie pointed out at the top of the hour, we have made huge strides in Rhode Island in terms of reducing the rate of uninsured. And that's something to really be proud of in Rhode Island. People who came well before me had a lot to do with that in terms of creating an infrastructure and an integrated system with our partners at EOHHS and within government to ensure that we really took all levers under the ACA and put them to the advantage of our marketplace to get people covered. And we are now, I think, number 4 in the nation in terms of our rate of insured, which is great. That said, one of the things that we continue to be concerned about as we look at our enrollment is access, right? Or pushing beyond coverage to access and ability to seek coverage. And when you have folks in what we refer to as bronze and even silver level plans, and those metal levels are used to describe the actuarial value of the plan. They range from bronze, which is a lower premium, higher out-of-pocket expense, all the way up to a platinum level plan, which is much more in terms of premium, but you're experiencing a greater level of protection as the insured person, and generally speaking have less out-of-pocket expenses. We've had a lot of enrollment in bronze and silver level plans over the last several years because consumers are really driven by that premium price. And when they are shopping and comparing plans through the marketplace, as I think most of us would do, they are drawn to the lowest monthly cost without, I think, a full appreciation for how insurance works, and that monthly premium, though it may feel affordable, is exposing you over the course of the year to a very high deductible and a lot of out-of-pocket expenses. So one of the things that we've been really excited and encouraged to see nationally, but also it resonates in Rhode Island, is that with the additional federal subsidy assistance that was made available under the American Rescue Plan Act and recently extended under the Inflation Reduction Act, we have more affordability assistance than ever before through the marketplace. And what that means is our customers have greater purchasing power. So when they come onto the exchange, their tax credit is going to stretch further than it used to. And we've seen a migration from bronze and silver level plans into gold and even platinum level plans. We used to have like a couple hundred enrollments in platinum, and now it's like a viable product on the exchange. And that's translating to greater protection, a richer product that Rhode Islanders are able to take advantage of. Now, where I'd like to see that go next is helping our enrolled, and this doesn't just apply to the individual and family side, this could apply to the small group market, to the large group market, to the state employee population. We need to help people understand that trade-off. We thought we would be having these conversations several years ago with our population, it's a hard conversation to have, right? We spend 40 minutes just getting somebody eligible for coverage, getting them to pick a plan. And then we're so excited to talk to them about what that coverage gets them and how to use it, what a value-based plan is and why it matters. We haven't gotten there yet. So I think looking towards creating a more educated consumer, one who is thinking about the purchase of an insurance product as sort of a financial protection and a financial tool for their family to help protect them from greater out-of-pocket expenses and ensure that they can get the services they need. One other thing I'll just touch on briefly is because it feels important to talk about as we look out across, all insured lives in Rhode Island and risks, is that we have over a third of our population in Rhode Island enrolled in the Medicaid program. That enrollment has grown exponentially over the last couple of years due to special rules that are in place under the Public Health Emergency Declaration related to COVID-19. In the coming year or two, that entire population needs to be redetermined to see if they are still eligible for Medicaid. And many, many thousands of them will not be, and they need to migrate to other coverage. So that is a huge transition that many of us in the carrier world and in the state health policy world are very concerned about. And I think it's a really unique opportunity to take a look at the way that we support health coverage, and we can use this as an opportunity to sort of reduce the friction between health coverage programs. We know that people move, people's income and household size and other factors that impact what they're eligible for changes all the time. We've always known that, and we've always been really terrible at supporting people through changes in program eligibility. So this is a great opportunity to take a look at how we can reduce that friction, support people in getting where they need to go to stay covered, because what we do not want is, after 10 years of implementing the ACA and putting it to work for Rhode Island, to go backwards and see coverage losses due to that big transition.
Great, thank you, Lindsay. That was very, very helpful. So now you've all gotten a feel for the panelists and what they do and what they know and what their experience is. And I'm hoping that there are some questions from those of you here that you want to ask either all of the panelists or some of the panelists. I'll give you a couple minutes. And I know, Sandy, you're checking to see if there are any questions coming in from the viewers. Okay, great. All right. Anybody here have a question? Yes, sir. Thank you.
Being a bit on the outside looking in, when we look at costs, what could be absorbed as far as cost goes if the individual citizen patient really worked hard and put the best effort in to be healthy, as opposed to just maybe looking to get treated for something? What % of resources could be saved just by the willing behavior of people? I think the word used to be compliant. I remember asking someone who was a physician who was involved with diabetes, and I said, what % of your patients actually do what you ask them to do? And I said, what would your workload be like if they actually did? He said, I'd be down 60%. So I just was wondering, for the whole healthcare system, is the problem really us, the consumer? And how big a role might that play in cost savings, just by the desire for the population to be healthy? Anybody even look at that?
I know how you've done a lot of work looking at some of the provider behaviors as well as
Yeah, I'm
consumer
not certain I
behaviors.
do it from a public health point of view, but if you look at Rhode Island's inpatient population has declined relatively substantially, but yet no costs have come out of inpatient. Those, the costs that would have normally been spent had you had, let's say, 120,000 admissions or discharges in the state, and now maybe you've got 100,000. Don't hold me to the numbers. But if it went down, let's say 20%, more costs have come into inpatient. So it's basically stayed the same or gone up. So I'm not so certain it's a matter of if people get healthy, healthcare costs will go down. I just am not one who believes in that, frankly.
And take a look at that holistic approach.
Yeah, so I'll say a couple of things. The intent of value-based care is to keep patients healthy and out of the hospital, better quality, better outcomes. That reduces the overall cost of care and improves their experience. I think what you're asking, I think when a provider generally approaches value-based care, you think of it as what type of additional capabilities can I bring to create that additional level of support for the patient? Do I bring in expanded care teams to support the patient? Do I get better analyzing my data to understand which patients need more support? Do I think about using that risk stratification to vary how frequently I'm seeing certain patients and differentiate the amount of care I'm giving to the high risk patients? That's provider muscle, right? Or payer muscle, or payer provider collaboration muscle. And when those models work well, you can easily start talking about taking 5 to 10% of cost out of the system that turns into savings for the provider. But that's providers working to deliver care differently. That's not, I think, the subtlety of your question, which is, what if every resident in the state of Rhode Island took a different approach? And then I don't know how to quantify that, but it'd be a lot more than 5 to 10% of healthcare costs that you see in value-based performance.
One of the things that we know from research is that that of the cost of healthcare, about 20% is actually focused in on the doctor's office, and 80% of it comes from other things, the social determinants of health. And so your question is I think, part of what we ask every day, which is, how do we keep people healthy? How can we keep people healthy? And, to your point with somebody with diabetes, are the streets where they live safe to walk so that they can exercise? Are there food deserts in where they live? Can they get healthy foods? So when we talk about keeping people healthy, the other way of thinking about it is, what's the investment that we need to make in the social determinants of health so that people have the chance to do what they need to do? We want to think about how we change the system around people and keep them out of that 20% of the doctor's office. But there's a lot of work that needs to happen on the side of helping them to be healthy, and thinking about it in an investment way is, I think, how we do that at AOHHS.
Isn't Rhode Island the perfect size and shape, so to speak, other than the demographics being old? But I think that that's part of it also, is that a lot can be done there to really do some of the innovation that's necessary.
That's a great point. Thank you. Yes, did you have a question?
Yeah, I wanted to pivot off of Al's point and off of Marty's point. So we're talking about making investments in opportunities to keep patients out of the hospital and keep their costs low. The point you were making was that the investment is going to need to be compensated by savings elsewhere, presumably in the downstream stuff. And I'm trying to figure out how to reconcile that with the universe where our average profitability is 0.5. Is that a structural issue? Is that the nature of the markets?
Well, I mean, with respect to, if you're bringing, I mean, to your point, if you get people healthy, they stay out of the hospital. Okay, fine. If you don't go to the hospital, you're not going to cost anyone anything. That's a saving. But what we've seen over the last 10, 15, or even 20 years, here in Rhode Island, for example, you've taken 3 hospitals out over, I guess, 30 years or whatever it is. In 2018, I guess, 40 million came out of the system from Pawtucket Memorial, and that was down from 80 or so a year or two before that. We've not seen an appreciable change in premiums or anything that reflects that. So I look at things from two different points of view. I think that the wellness idea, people getting healthy, quitting smoking, all that, that's wonderful. We should do that. But I don't personally believe that major affordability change will be made without focusing on the financing of the system. Plain and simple. And I think in the fee-for-service environment, all of the kinds of things that you're talking about, workforce, it's all exacerbated because the incentive is to pack people in the hospital. And so, you know, if anything, if you ask me one concept, just one concept, I would say payment reform. And I think that we have an opportunity here in Rhode Island with this compact that's been recently signed, where we've got a discussion going on about global budgeting for hospitals, capitation for primary care docs, which I view, by the way, is a way of giving primary care docs more money, needed money, and capitation for specialty costs. The hospital and the specialist for small and large group premiums are the two biggest buckets. The RX is the one that's most rapidly increasing, but I think the one that's more manageable is engaging specialists and doing something different in hospitals. And when I say something different, I literally mean not off-the-shelf ACO model. I mean, talking about what can we do with respect to payment reform and what will payment reform drive in behavior. Maybe one more second, Marie. So I was part of an experiment that was kind of shoved down our throats by Blue Cross of Rochester, by Kodak, Xerox, and Bausch and Lomb. And shoved down our throats, what I meant was, we had been doing a lot of complaining about margin. So it's not the first group of hospital administrators that have complained about margin. And finally, the trustees said to us, we'll do something about it. And over a series of a year or two, we came up with this HEP experiment. It's a book written on it in 2012. When Clinton was running for his first term, he said if they can do it in Rochester, they can do it any place. And during the 10-year period, we underspent the national average for hospital expenses by $0.5 billion. That sounds like a lot of money, but it's a big budget. It ended up being 2 to 3, maybe 3.5% of total expenses. That is to say, had we spent at the national average, we would have spent 0.5 billion more. The experiment ended because Medicare didn't want any experiments anymore because they had brought out the DRG system, which was solved all the problems. Now look how that came out. And in the succeeding 10 years, we overspent the national average by $1.6 billion. And nothing changed. There were still 10 or 11 hospitals, 3,000 docs, a little less than 1 million people. Nothing changed. It just, we went from being incentivized to focus on our expenses to being incentivized to focus on our revenues. And that's exactly what we did.
Thank you. I think all of will have a
Can I
really
just
good.
add to that super quickly? Or
Sure.
were you
Go ahead,
gonna-
and then
Oh,
Okay.
Okay, I'll be
Okay,
brief.
Nick.
I think we tend to talk about hospitals and reducing emissions because it's a tangible example, but we have cost issues everywhere, right? Our specialist spend is out of control. Our drug spend this year, specialty drugs, is out of control. And so you could take a system of care here, they're taking risk on the drug spend right now, figure out how to better control that through better med management, through embedding more pharmacists, or go to a specialty practice and embed more pharmacists, reduce that spend, and that becomes profit. That's not getting, it becomes a new profit, new revenue for the system. It's not getting taken away from the system. It's getting taken away from a drug company that is now going to the system.
Thank you. Orla, your perspective will be helpful.
Yeah, I'm going to look at it a little bit differently, and it's primarily from the hospital view. So what we are seeing in the hospitals across lifespan is that our case mix index has gone up significantly. The patients that are coming into the hospital now are much sicker. They have held off care. They're not getting preventative screenings for mammograms, colonoscopies, the things we all used to do before the pandemic. And as a result, the acuity in the hospitals is much greater. And in addition to that, then is the behavioral health aspect. So to take care of patients in the hospital now, especially behavioral health, requires a one-to-one provider. Either it's a nursing assistant, it could be a security guard, it could be a nurse. And our costs, you talk about our costs increasing. The average nurse, if you've been out of nursing school for about 3 or 4 years, you're getting roughly about $40 an hour. What has happened is that the contract labor has taken over healthcare. And we are seeing nurses, physical therapists, pharmacists, CAT scan techs, MRI techs, respiratory therapists going and taking contracts in their own state within Rhode Island. They're going from Lifespan to Care New England to Roger Williams to any other hospital, Kent, and they're making approximately $160 to $200 an hour. So a nurse who was making $40 an hour is like, I'm going to leave and make $200 an hour. And that's allowed, and that's across our country, and it is killing hospital systems and probably nursing homes as well. And when you talk about high costs, how can you cut your costs when this is being allowed across the country? We can't close our doors in the emergency room. So whoever shows up, we have to take care of them. So we have to pay those nurses $200 an hour because the quality of care that they're going to get. We want value-based care, we want good quality care, but it's getting much more difficult to provide good quality care when we don't have a workforce that we can hire and recruit to because they're going to other places. And we're not alone here in Rhode Island. This is a national crisis that needs immediate attention. If we want to cut the costs of healthcare, I think, in my role, this has to be addressed first. We are paying nurses more than we are paying physicians, and that's wrong. And we talk about that on a regular basis at the hospital, but it's crippling the finances in healthcare systems.
Thank you, Marla. Thank you for that. Did you have a question?
Yeah, I actually do. I'm a hospital person as well, but I've worked on the physician practice side. And, you know, we talk about like the cost of healthcare, right? When you look at it from a hospital side, hospital costs are fixed for the most part. I could see 10,000 patients, or I could see 8,000 patients. I'm going to have some variable costs. It's going to be like nursing costs and pharmacy costs that will be in there. But a lot of my cost is going to be fixed. That's just a fact. It really kind of is. Yeah, I think when you think about it, like the cost of drugs, the cost of labor that we're having to pay now, it's becoming like Orla said, very crippling on the cost into the system. And it's really the cost on the hospitals. I mean, they're the ones that are really bearing the biggest burden of the cost of this. You know, all of a sudden, my labor cost goes up 150, 200% or more. Payers aren't paying anymore for that, you know. Not saying they should, probably, you know, they probably should, but I don't know, because I think that will eventually actually flatten out at some point. But the main piece, and I think it comes back to like, do we as the general public not take care of our own selves from that standpoint? But how do we do that when we don't have good access today? I mean, I've worked for probably 8, 10 companies, right? And it's all about access. There's not a company I work for that did not have a need for primary care physicians. Well, when you don't have that, you know what becomes primary care? Your ED. That's where cost comes into the system, right there. And so fundamentally, we have to look at how we're going to change that. Yeah, and if I will tell you, if I were looking to go into med school now, but a primary care doctor comes out, a nurse practitioner can make almost as much as a primary care physician coming out of school and doesn't have the debt that's associated with it. I mean, somehow fundamentally, the pandemic has really made us take a step back and look at how we really deliver healthcare. But all of us are now going back looking about, well, look at 2019 and how do we get back to that? If we do that, we're absolutely going to struggle as an industry. And I think you're going to see more facilities that are going to close and you're going to have less access than we do today. I don't have the answer to that. There's no silver bullet to that. But I think we as healthcare professionals have got to figure out a way to start addressing that need.
Thank you. Anybody want to add to that? All right, thank you. I'm going to actually put somebody on the spot for the last couple of minutes. And I know there's some work going on at EOHHS relative to workforce. And so Marty, do you have a little bit to let us know that how we may be advancing this agenda at the state level?
Yes, sure. Thank you. So we are working in partnership with the Department of Labor and Training and the Office of the Post-Secondary. We have 3 active work groups that meet monthly, and you're all invited to attend. Tomorrow morning is the one that I co-facilitate on data. So it's asking the questions, what do we know? What do we know about the workforce that we have, the workforce that we need? There's a lot of data that we don't have, and we're desperately trying to figure out better ways to get that data. And we've got folks involved from behavioral health, and we're pushing for more behavioral health involvement in the work groups and to the hospitals and to the nurses and long-term care. The second work group is focused on higher education. Who are we educating? It comes back to data. Who should we be educating? Where is the need, and how do we match the education that we're doing with the need that there is? So those 2 groups are working together. And of course, we are working with the third group, which is career ladders. So what are the career ladders? What are the options? How do we make sure that the diversity that we see in our CNAs, for example, which is a pretty diverse group of people, is still there when we go up to the highest professional levels of our workforce? How do we make sure that that we have the ladders and lattices and ways to bring people up through the system? And again, how do we know when we need the data? So those 3 work groups are happening, and we are involving as many people as we can. Each of those work groups has an executive sponsor. Secretary of EOHHS is the sponsor of the data one, the Office of the Post-Secondary, the higher ed, and the Department of Labor and Training for the career ladders. And we started saying that these work groups were going to push for action. So we are increasing the types of data that are available. We are working on data sharing and trying to figure out. So I know this the most because this is the work that I've been doing. How do we, when folks are re-upping their licenses, how can we get some more data from that process to really learn who is working? We know that there are probably thousands of people with licenses who are not working in healthcare, and then certainly people who are not working at the top of their license, which is a critical piece. And we are looking to, I'm on the group that is coordinating the work, and we're trying to figure out where to go next from a strategic level. So we started on purpose, very tactically short term, let's get some stuff done. And then we're going to sort of knit it together to be more and more strategic. And again, these are open work groups. The meetings that we have are all, these are actually in person. We wanted to just go deep and be in person, but we're thinking about other ways of engaging folks. So I don't know, Sandy, feel free to share my email address and I will get you. Ariana Husky is the person that you will hear from. She is our project manager. If you want to get involved, we'd love to have you.
Thank you. So we leave on a hopeful note that we're advancing an agenda here at the state level. So I hope that you will join me in a round of applause for the panelists. Thank you. Thank you so much.
And to thank you to Dr. Ganem for moderating this evening's event. So again, thank you for joining us. Those of you joining us online, this is one of our many leadership lecture series webinars that we've been doing through the Masters of Healthcare Leadership. You can visit that online for past a recording of tonight's events and for future events. And particularly want to thank both groups, both the School Professional Studies and the American College of Healthcare Executives for co-sponsoring tonight's event. For those of you that may be online and are regional, please visit the Rhode Island American College of Healthcare Executives website, and you can contact many of us on the board, particularly Dr. Brandos is the president of the board, and we can engage you in the community. Thank you. That concludes the online portion of tonight's event.